Good afternoon, everyone. Thank you for joining us today. Welcome to the NCCRED webinar series. The series is a bi-monthly seminar program delivered by the National Center for Clinical Research on Emerging Drugs. And the aim of the series is really to promote innovative practice and share learnings and new ideas amongst clinicians and clinical researchers working in the field of methamphetamine, emerging drugs, and other areas of alcohol and drug health. I would like to start the webinar today by acknowledging and paying our respects to the traditional custodians of the lands and waters of Australia and all First Nations elders, past, present, and emerging, especially those who may be joining us here today. We respectfully acknowledge the traditional custodians of the land and waters and their continuing cultural, spiritual customs and practices. Before we get started, please remember that there will be a recording available after this session that will be freely available for you to share with colleagues, peers, or consumers you feel may be interested. You'll find it and all of our previous seminars and video abstracts, etc., on the NCCRED website. Today's webinar is on GHB insights for service providers. So this seminar topic was selected in response to emerging data around harms associated with GHB from EDs nationally, and in response to clinicians requesting more information on changing demographics in GHB use, harm reduction learning, and withdrawal management. We're going to start the webinar with an overview of these topics, followed by a panel discussion. So firstly, before we get into the panel discussion, I would like to introduce Jack Freestone. Jack is a postdoctoral research fellow with the National Center for Clinical Research on Emerging Drugs. Prior to commencing with NCCRED, Jack worked at ACON, where he managed ACON's drug and alcohol programs, and later ACON's HIV and sexual health programs. While working on ACON, Jack completed his PhD at the Kirby Institute. Jack's PhD research focused on the development and implementation of peer-led interventions addressing sexualized use of GHB and crystal methamphetamine. Thank you, Jack.
Thank you, Krista. Krista, are you planning to do the background slides now?
Sure. So I can lead out with some background around GHB. So this is Jack sharing his screen. So we'll work together on delivering these data. So a bit of background, GHB and its precursor chemicals, GBL and 1,4-BD, are CNS depressants known for their mood and libido enhancing effects. Some of the street names that you may have heard GHB referred to include G, juice, drink, liquid E, fantasy, or fishies, hence the little fishies that you've seen on the previous slide. GHB usually comes as a liquid and it's sold in vials, bottles, or fish-shaped soy sauce containers. It's odorless and can have either a bitter or salty taste. Less often, you can find it in the form of a white powder. It's usually swallowed, but it could be injected, snorted, or inserted anally. GHB in itself is endogenous in terms of a naturally occurring neurochemical, but it's both a precursor and metabolite of GABA. So GHB and its precursors, GBL and 1,4-BD, can cause a desired effect of stimulant effect, which might be the desired rationale for use, which can make sort of feelings of euphoria and disinhibition. But at higher doses, which are very close to the lower doses, so we're talking the difference of a very small amount, at higher doses, GHB becomes a potent CNS depressant. So because obviously people are purchasing GHB in an unregulated market, people may not be aware which chemical they're taking, whether it's GHB, GBL, or 1,4-BD. It may all be sold interchangeably as GHB. And our recent survey findings of people who take GHB, we surveyed 186 folks and found that about a quarter of these were unsure which formulation they were actually taking. And almost 10% actually indicated that their purchase didn't meet their expectation when they ended up taking what they thought had been GHB as the purchase point. So one sort of important thing to note in terms of harm reduction and harm minimization around that, that sort of missold or mischaracterized GHB is that 1,4-BD in particular is metabolized by alcohol dehydrogenase. So when 1,4-BD is consumed with alcohol, it basically competes on that alcohol dehydrogenase and can be, and therefore the alcohol can saturate the alcohol dehydrogenase can then become saturated, and this delays the metabolism of 1,4-BD into GHB. So this causes like a delayed onset. So basically, someone can take the GHB, not feel its effects, not recognizing that the alcohol has replaced the GHB, and then later end up with intoxication because of the delayed impact of that 1,4-BD. In the most recent Australian household surveys in 2022-23, no changes were reported compared to 2019 data. Approximately 1% of people greater than 14 years of age in Australia had consumed GHB. However, rates amongst LGBTQ people in Australia have been documented as 20 to 54 times higher than that. In Australia, GHB has been predominantly associated and reported around sex-based sociality and predominantly amongst men who have sex with men. So there's been sort of a bunch of recent reports that demonstrate a changing demographic in terms of the harms associated with GHB use. So in one case series of EDNA participants, so this is an emergency toxo-surveillance project that's run nationally between April 2020 and July 2022 across 3 Western Australia emergency departments. GHB was detected in 45 presentations, and 53% of those were actually in women. And then in Southwestern Sydney LHD, sort of over the COVID period between March 2019 and March 2021, 84 admissions for GHB-related disorder identified more than half of those that were admitted for withdrawal or toxicity. 56% required withdrawal support. And again, this was about an even split between men and women in that sample. And then recent data across 4 metropolitan emergency departments in Adelaide over a 15-month period recognized that of 1,100 patients who were tested presenting with symptoms of drug intoxication, just over a quarter were actually positive for GHB. And this was almost always used in the context of methamphetamine as well. So in 83% of those participants, methamphetamine was detected as well. Again, a higher proportion of women tested positive for GHB than men. So in these data, we're sort of seeing a shift away from what we know in the literature to be sort of a predominantly drug use predominantly in context of men who have sex with men. And this literature is kind of starting to shift across to thinking about who else might be using this drug and who's running into or encountering harms such as emergency needs for healthcare. And there's data coming out of New South Wales coming up soon. That'll be at the ABSAD conference in a couple of months' time, kind of supporting this changing demographic. I think this is the same slide. Yeah. There's other data too from emergency departments across 4 Sydney emergency departments that we've done where we looked at trends over time from 2012 to 2021, where we identified that there was a 114% increase in GHB related admissions and the acuity of those presentations. So more likelihood to present as category 1 or category 2 on admission. And again, women represented almost half, but certainly higher over time, increasing over time. And these data complement sort of the emergency response data from Victoria that was also published sort of in an earlier time frame than this, whereby ambulance callouts for GHB over time had a 147% increase. Next slide, please. So regular consumption of GHB or its analog chemicals can result in dependence, and that can be complicated by withdrawal syndrome. That withdrawal syndrome is less likely if the patient has been able to experience greater than a day without GHB in the prior week. So really just that level of regular independent use. Consuming higher amounts more frequently, so waking in the night to dose or longer duration of use have also been associated with complicated withdrawal. So these are just some things you might be thinking of when people attend seeking support for a withdrawal. The onset of withdrawal can be rapid and it can commence within as early as an hour of discontinuing GHB use, and it usually has symptoms that peak within that first day. It can last up to 3 weeks as a sort of prodromal syndrome. And while the symptoms are not well described, severe and complicated withdrawal has been characterized by particularly delirium, as well as auditory or visual hallucinations, agitation, tremor, and seizures. So withdrawal, because of those risks for medical complications and psychiatric complications, can require a medical management. And there are limited studies, often underpowered. They're predominantly case series or open label trials that report on medical management of GHB withdrawal. That includes pharmacotherapy, which might be a benzodiazepine, or titration and tapering of a pharmaceutical GHB called sodium oxybate, which is not available in Australia, but you might have read about in other European settings, for example. Barbiturates such as phenobarb. That's a leftover. Stay tuned for next talk from an old slide deck, but I think we'll be touching on this in a moment. And then newer data coming out around baclofen, as well as gabapentin and antipsychotics, which are less commonly reported, but also described as supportive measures for GHB withdrawal.
Thanks,
And I'll hand
Krista.
over to Jack.
Yeah. Thank you, Krista. I'm going to talk through some research that NCCRED has conducted among people in Australia who use GHB. And I just want to flag before I get into this content that some of the content that I'm going to talk about pertains to sexual violence, which is obviously quite a sensitive topic for many people. So if that's a sensitive topic for you, please feel free to tune out for about the next 10 minutes. I'm going to cover the data in relation to the qualitative research around GHB in a fairly high-level way, acknowledging that most of the data that I'm going to cover is available in open access journal articles. And if there's anything that I say that you have questions about as we go along, please feel free to put those questions in the chat and we can come back to it when we have our Q&A section. So in 2021, NCCRED led in collaboration with a range of other organizations and stakeholders, the GHB Cultures, Practices and Experiences study. This was a study that was conducted alongside clinicians and researchers, and really importantly, people with lived experience. The GHB Cultures, Practices and Experiences study was conducted in two phases. So the first phase was qualitative research, which was conducted among LGBTQ+ populations. And we did that with that study with this focus in acknowledgement of the data which Krista has pointed to, which indicates a long-standing, more prevalent use of GHB among certain LGBTQ+ populations. And then the phase 2 of the study, which engaged a sample of cisgender and heterosexual participants in acknowledgement of emerging data that people who are presenting at services and emergency department around GHB are coming from a broader range of demographics. So really with this study, what we wanted to do was focus on community attitudes and perceptions and practices around GHB and harm reduction. And in taking that focus, we wanted to look at where there was real strengths in practice, which we could leverage in our education responses, but also where there might be shortfalls in knowledge and practice, which we can address via harm reduction education responses. So to conduct phase 1 of the study among LGBTQ+ people, we interviewed 31 people who identified as LGBTQ+ and who reported 3 or more occasions of GHB use in the previous 12 months. Interviews were transcribed verbatim, and then we conducted a thematic framework analysis of our interviewed data. The first study emerging from phase 1 of this research was called Controlling for Pleasure and Risk, the Experiences of Sexuality in Gender Diverse People Who Use GHB. And that paper really documented some of the motivations that people report around using GHB. And those motivations at a high level were motivations associated with pleasure. So pleasure associated with the feeling of GHB and the sensation of it, but also associated with the connection that people experience around GHB use, specifically around GHB facilitated sex. In this paper as well, we document how participants narrated control in regards to GHB use and the harm reduction strategies they use really to prevent GHB overdose. Now, these harm reduction strategies are strategies that many of us on this call have probably heard about before in relation to GHB. So their approaches like careful measuring of GHB using a measuring instrument with clear markings on it, careful timing of GHB dose to ensure that you don't redose within, say, 2 hours of an initial dose of GHB, and using a timer on your phone to support that. And also caution with regards to combining GHB with other central nervous system depressants, so things like benzos or opiates or alcohol. Now, I think despite caution and careful practice around these harm reduction strategies, most people in our sample, 17 out of 31, had personally experienced GHB overdose. And that aligns with the international evidence base on GHB, which really indicates a highly prevalent experience of overdose among people who use GHB. So prior to us starting this research, our colleagues at NDARC had conducted a coronial review of GHB-related mortality here in Australia. And that coronial review found a number of things. First, that most people who died after using GHB had been using in a private or domestic setting. Most people had been using with other people, and the people who they'd been using with hadn't intervened or called 000 when that person who sadly passed away had experienced an overdose. So we looked at the evidence around GHB and we actually found very little qualitative research about how people understand overdose and how they respond when they're a bystander to a GHB overdose. So we conducted this analysis and we documented that analysis in the paper, which is pictured there, called Understanding Attitudes, Practices, and Responses to GHB Overdose Among GHB Consumers. And in this analysis, we found that participants were using a number of terms to connote experiences of GHB overdose. These were terms like G'ing out or blowout or GHB drop. And they really defined GHB overdose in accordance with 3 different strata. So first, there were those symptoms of distress, which could be things like contortions, sweating, zoning out, a state of agitated animation, or conversely, a state of nearing sleep, so sort of nodding off. After that, we saw people describe GHB overdose in terms of GHB-induced sleep. Now, this sleep was largely regarded as something which was transient and harmless. And then the third strata was this notion of GHB-induced sleep, where someone was also completely unresponsive to pain or sound stimuli. And this strata of overdose or understanding of overdose was largely regarded as kind of the one which was in requirement of most intervention. I think that relationship between, say, strata 2 and 3 there is nicely reflected on by Emily, who was a trans woman who was queer in her 20s, who said, if someone is responsive, maybe they're not talking, but they will open their eyes. If someone says their name, that for me is like, okay, this person's had too much, but it's not at a level yet where I think they're in danger of dying. As opposed to if someone is passed out, completely unresponsive, they're shallow breathing, that kind of stuff. That for me is like, there's nothing we can do here except call an ambulance. So Emily reflects on the relationship between, say, GHB-induced sleep and then GHB induced sleep where someone's completely unresponsive to pain or sound stimuli, but also articulates, strata 3 as the threshold at which an ambulance should be called. And we explored people's perceptions and practices around 000 call. And our data indicated that there were a number of factors which discourage 000 call. Now, these factors might be familiar to, I guess, a broader population of people who use drugs, but the discouraging factors look like cost and fear about making someone liable to pay a fee, concern about distress associated with hospitalization, concern about legal ramifications and police co-attendance, concerns about the overdose environment and inviting 000 into a context where, say, sex was occurring or where other drugs were present or where it was somebody else's residence, and also prior experience of GHB overdose in the sense that GHB overdose is something transient and ultimately not harmful. This kind of relates to that notion of an individual's confidence to manage GHB overdose. And many people in our study reported that they had experienced several GHB overdoses previously and they felt very confident to manage a GHB overdose, so therefore they wouldn't call 000. By contrast, several people said the point at which somebody perceptibly falls asleep after using GHB is the point at which I will call 000. In certain instances, people spoke about peer pressure as facilitating ambulance call out, and in other instances, people spoke about peer pressure as inhibiting ambulance call out. But by and large, most people were making decisions about whether or not to call 000 based on an assessment of a person's breathing and their ability to respond. Where breathing was deemed normal and someone was able to respond, they wouldn't call 000. But if someone couldn't respond, or shallow or interrupted breathing was observed, 000 would be called. In our data, three participants recounted experiences of others accidentally ingesting a large volume of GHB, thinking that it was water. So GHB had been stored in an unmarked container. And in all three instances, that person immediately called 000. So the next thing we looked at within this data was around GHB, sex, and consent. There's been a number of prior studies which have documented concerns regarding GHB and experiences of sexual violence. And a lot of that research has been conducted among gay and bisexual men who have sex with men. However, in our study, we saw that most of our participants, so 28 out of 31, were using G for the express purpose of enhancing sex, regardless of sexuality and gender. And we wanted to ask these participants, how do you navigate GHB sex in a way which is gratifying? And how do you ensure that sex is consensual and ultimately safe? And people reported a range of strategies in response to these kinds of questions. First and foremost, people often spoke about adopting strategies in support of what we might call affirmative consent. So those are strategies whereby people negotiate and agree on their sexual boundaries and interests and limits ahead of sex occurring. Less commonly reported were strategies in service of what I'll call continuous consent, which is basically ensuring that consent is present throughout the entire duration of a sexual encounter. And strategies in service of continuous consent can be both verbal communication strategies, but also non-verbal communication strategies. Some participants were engaged with these, but not many. Also in our data, we had several participants who narrated experiences of others initiating or continuing sex with them after they'd become unresponsive, after they'd used GHB. And in nearly all cases, participants reported that these experiences were distressing, but in nearly all cases, participants resisted labeling these experiences as sexually violent. We can see this kind of play out in Martin's quote, and Martin says here, I suppose if you looked at it on paper without emotion and names attached to it, you could describe that as sexual assault. I suppose my view would be that's up to me to decide whether I felt violated and whether I was assaulted, and I don't. Now we'll come back to the sort of the implications of that sentiment when we wrap this up. Before I get there, I just want to briefly talk about the qualitative work that was conducted among a sample of heterosexual and cisgender participants. So I'm talking about this in a fairly high level way, just with acknowledgement that I personally didn't lead the data collection or analysis on this work, but I was involved and I can give you an overall summary. So there were 26 people who were interviewed in this phase of the study, and the protocol reflected phase 1 protocols. So people had to report 3 or more occasions of GHB use in the previous 12 months. These people were engaged via semi-structured interviews, which were transcribed verbatim, and the data were analyzed thematically. We saw the results of this study echo and mirror a number of the results from the LGBTQ plus study. So first we saw participants in this study, their patterns of GHB use fell into 3 distinct patterns, those being occasional, regular, and dependent. Again, in this study, we saw overdose risk mitigated through a range of fairly well-articulated harm reduction and self-regulation strategies. Yet again, overdose in this sample was common. Overdose infrequently resulted in hospitalization, and most episodes of overdose were in fact managed by peers. A resounding barrier to calling 000 in this data was fear of police and prosecution. And in this sample of people, we saw vigilance around sexual violence, and it was common for women in the study to describe a culture of women looking after women in relation to GHB and potential sexual violence. So I said when I started describing this work that we wanted to conduct this research to inform our harm reduction education. And so what really did we learn from these studies? Well, I think first up, we learned that we need to reinforce those effective GHB overdose prevention strategies. So those are strategies of caution around how you measure your GHB dose, how you time your GHB dosing interval, and what drugs you combine GHB with. I think we also need to acknowledge that there can be real barriers to people calling 000, and a lot of those barriers are structural barriers. So while I think we need to continue to encourage people to call 000 in response to GHB overdose, we need to acknowledge that a lot of the time these overdoses are being managed by communities and by peers, and we need to be sure that we're providing people with ample education around managing airways and checking breathing. With regards to sex, I think we want to reinforce some of those positive practices around sexual communication and affirmative consent, while also amplifying some strategies that are in service of continuous consent. And then with regards to experiences of distress, which aren't really labeled as sexual violence, I think that when we're supporting people who use GHB and when that use is in the context of sex, we need to acknowledge that those people may have experienced distressing events around GHB sex, but they might resist sexual violence labeling, but still require some support around these experiences. So that's my wrap up. We produced a summary of phase 1 of this research via a short video abstract, and that's linked there on the slide with a QR code. Krista, I'm going to pass back over to you to talk through some data on GHB withdrawal before we get on to our panel discussion.
Great, thanks, Jack. So we have looked at the data in the broader literature and then again in our own samples just to determine how we manage GHB withdrawal and what's available to us in the Australian context. So we did 2 projects that were retrospective review of one St. Vincent's Hospital all cases who were admitted for withdrawal of GHB in our withdrawal unit, and one that included St. Vincent's and Liverpool data, and that included cases who received phenobarbital to support them through their or facilitate them through their GHB withdrawal. The data was from January 1st, 2017 to the 31st of March, 2021. And again, we included all cases who presented within that timeline who were adults admitted for withdrawal with documented recent GHB use. We also characterized this before and after the implementation of a withdrawal procedure at St. Vincent's Hospital. So both of these studies are published. The first study looked at how we manage GHB withdrawal at St. Vincent's. We recorded 135 admissions, and those were across 91 distinct people, patients. And across those admissions, the medications administered were almost always inclusive of diazepam. Antipsychotics were also quite frequently used in over half of the participants, particularly olanzapine. Baclofen was used in nearly all participants after the introduction of the procedure, and fewer prior. And phenobarbital was used in 8 admissions, which will be in study number 2 in just a moment. So we looked particularly at the 21 presentations that had features of delirium. And we found that delirium was associated with higher daily GHB consumption prior to the withdrawal. However, the duration of GHB use, the time from presentation to hospital to the first dose of diazepam, and concomitant methamphetamine use were actually inversely associated with delirium. And early discharge, when it was not deemed to be medically safe to leave the hospital, occurred amongst 30% of these cases. And that was associated with a longer time from the presentation to hospital to the first dose of baclofen, while being a woman or receiving an early loading dose of diazepam were actually inversely associated. And then we looked just at the phenobarbital participants. So that was 13 cases of 12 distinct people. And the median cumulative dose of oral diazepam prior to commencing the phenobarb was in range of 80 to 255 milligrams. but on average 120 milligrams before phenobarb was introduced. The median time from the last dose of GHB to the first dose of phenobarb was about 24 hours. This ranged from 7 to 57. And 8 of these cases received phenobarb orally on a general ward, while 5 were administered by IV in an intensive care setting. All participants experienced an improvement in GHB withdrawal symptoms after phenobarb, and there were no adverse events related to the phenobarb. I do want to sort of stop Jack and I now and go ahead and introduce our panel. So this panel will be available now to take any questions. So please, I can see that a couple of questions have already come into the Q&A. So please start putting your questions in the Q&A while I introduce the folks that we have here online. So first we have Erica Franklin. Erica has a degree in criminology and criminal justice and completed an honors thesis focused on why people are motivated to take novel psychoactive substances. She's worked at NSPs, drug consumption rooms, research centers, drug checking services, and has extensive experience delivering peer-based harm reduction initiatives at music festivals and nightlife settings across New South Wales, ACT, and the Northern Territory. Erica is deeply committed to empowering communities and championing human rights. She's been an active member of Reclaim the Streets, organizing large-scale protestables that have addressed critical issues such as marriage equality, trans nightlife safety, and drug user rights and drug law reform. Also joining us today, Michelle Lang is the nurse unit manager of the Gorman unit at St. Vincent's Hospital. Gorman is a medically supervised alcohol and drug short stay unit that provides 5 to 7 days of inpatient withdrawal management. Gorman provides specialist care in managing withdrawal symptoms, psychosocial support, and post-discharge planning. It's a voluntary service, and Michelle has experience in drug and alcohol, emergency, and psychiatric nursing. Originally from the UK, Michelle has lived in Australia for 16 years. Jess Graham is the CNS2 of the Gorman unit at St. Vincent's Hospital, and since graduating over 10 years ago, she's worked in different areas of Sydney within drug health services, specializing particularly in inpatient withdrawal management. She returned to the inpatient setting at the Drug and Alcohol Gorman unit in 2022 after a few years training and practicing as a midwife in Western Sydney. And finally, we have Nadine Ezard, a professor of medicine at UNSW, director of the National Centre for Clinical Research in Emerging Drugs, and clinical director at St. Vincent's Hospital, Sydney, and Alcohol Drug Service. So thank you all so much for joining me today. I'm going to lead out with a question for Erica. So Erica, I'm going to ask, what kind of things do you educate your peers on when it comes to GHB overdose? Specifically, what things do you share about responding when someone becomes unresponsive after G in the community setting?
Thank you. When it comes to educating, I guess, about GHB overdoses, first it's about harm reduction practices being dose sensitive, that it can have a stacking effect, the delay onset that you talked about, and really about interactions with other substances, both illicit, but also your own medications. These can have an effect, and also the set and setting. When it comes to GHB presentations, there can be a real variety of signs and symptoms. It can often have like quite hypoxic, so a reduced amount of oxygen to the brain, which can lead to people kind of going down and then up again, down and up again. So you can see people having contortions, nausea and vomiting, uncoordinated blackouts, irregular shallow breathing, confusion, unconscious and seizures. But it's really one of those things which you might see in a setting where somebody requires assistance, where they might be down for a moment, then they'll come up, they'll be lucid, and then all of a sudden they'll drop down. So we really want to communicate to people that people can actually deteriorate quite rapidly. All of a sudden, somebody could have a couple of little moments where you're a little worried about them, then they might be talking to you, and then all of a sudden they could begin to have a seizure. If you do see somebody or know somebody you're worried about them, they're not being responsive, one of the key things we communicate to people is not to stand directly in front of them when they're down. The last thing anybody wants when they've woken up and they're confused is somebody directly in the face. We recommend to come to the side of somebody, to give a little squeeze on the shoulder and stuff, because people who I've responded to who are experiencing GHB intoxication and potentially overdose, they can get up quite quickly and they can flail their arms. So it's about protecting your own safety. Recovery position is so unbelievably important. People can begin to vomit, and we want to make sure that airway is clear at all times. We don't want anyone Jimi Hendrixing themselves. So it's making sure that we've got the doctor's ABCD, We also need to be aware of the circumstances. It could be that they've taken too much themselves because they mistimed their doses. It can also be intentional that somebody's decided they want to go into, I guess, close to a G drop. It can be something that is a choice that some community members make. It could be that they've mistakenly had a drink. If the bottle or fish has not been clearly identified, it could also be that somebody has intentionally spiked their drink, or for the purpose of coercion. And it could be that this person might have experienced some form of sexual-based violence. So you need to be aware of these things when you're responding to it. We do make sure that we let people know to carry naloxone, because it can be quite difficult to determine through what is visually presenting to you whether this is a overdose that's related to opiates or whether it's a GHB. There is a difference in the pinned pupilness of the eyes. However, unless you're doing a toxicology on this person, you don't know what's in it. But if you're ever, it's always just worthwhile having naloxone on you and administering as needed, and making sure that people call for help. You're not going to get in trouble. But that's the basics of responding to it, and making sure after responding you get some support, because GHB overdoses can be quite confronting as an experience. They can be quite challenging. Making sure you get that support post supporting somebody else.
Thank you. And I think it's worth noting, just because we do have quite a broad stakeholder engagement for these webinars, so it's probably worth noting that in that context, naloxone will never be harmful to provide naloxone in those kinds of settings. So it's worth noting that as well. So we do have a question here that I think is probably suitable for Michelle and Jess, just regarding clinical management. So if you could describe what your procedure or local policy is for managing GHB withdrawal, particularly perhaps around pharmacotherapeutic interventions.
Yeah, we can help with that. We have a policy, we have a specific policy for management of withdrawal from GHB, and that's what we'll follow when someone who presents who says that is that one of their substances or their only substance that they're using. We always will want to know how much are they using, how often are they using, are they waking up at night to use, because those are the things that will really help us know if we're looking at a potential moderate to severe withdrawal, and we want to get in front of that. So with most of our clients, when they come in, they'll go on a loading dose of benzodiazepine, so diazepam, that's what we'll generally use. And then we have some symptomatic management as well. So we can put people on baclofen for a weaning dose, start 10 to 25 milligrams TDS and wean them during their stay. We'll also use clonidine, which can help with the restlessness and feeling generally unwell when they come in. We'll use olanzapine for agitation, if that suits that client. Anti-nausea. What else do we use?
Not so much pharmacological, but like getting onto them quickly as soon as they arrive. Basically, we'll be assessing when they last had any G. We'll be getting the treating team to chart that loading dose of the 20 milligrams an hour or two later, another 20, and another 20 another hour or two later, just until either 60 milligrams or lightly sedated.
Yeah.
And we have seen it kind of keep people pretty comfortable. And like you said, the baclofen, we start that at TDS and reduce that down.
I think it's important to note the first 24 hours are really quite important. That's when people can be at their most at risk of delirium, of withdrawal seizures, and it actually being a very uncomfortable withdrawal. A lot of people don't know how uncomfortable the withdrawal can be because they actually haven't maybe tried to stop in the community, or they have tried and they've had minor symptoms. But we've seen people when they come in and it's a really uncomfortable withdrawal. It's something that you do want to get on top of early. And I think it's also complicated by there's no specific tool that you can use like a CWA or a COWS to monitor signs and symptoms of withdrawal to help you with what you are going to give. So we very much educate our staff on this policy and make sure that we do have all the medications charted soon as someone arrives.
And how do you monitor for an escalation in symptoms? Like, how do you monitor for delirium in that setting?
Well, it's quite hard. We've just got to keep increased observations on patients who do disclose that they use GHB. And one of the things that we do when someone comes into our unit, we'll put them for the first 24 hours at least, 24 to 48 hours in a single room if we have one available, close to the nursing station. We'll do increased observation, vital signs, communicating with the patient, and then we can notice if there's any change in their cognitive state, which will help us know that we're actually going into delirium. And it's basically education with the nursing staff, but keeping that communication with the patient.
I think another thing we do is we admit them early in the week, so they're kind of, Monday, Tuesday, Wednesday often, that they're kind of more staff is around. We flag them every day between morning shift, afternoon shift. We flag people at risk for delirium, basically anyone who's come in who is using G, we flag automatically. Hospital policy is hourly obs for the first 4 hours when they arrive, and that includes your nursing assessment and your clinical judgment as to how they're going, and that kind of decreases not by much into 4th hourly for the first 24 hours as well. So your eyeballs are on them, you're assessing them all day.
But still a targeted symptomatic kind of withdrawal questionnaire and delirium screener would be on the wish list if you could do something to improve.
Very much on the wish list.
Great. Okay, thank you so much. And I want to just sort of take it from withdrawal back to that sort of acute toxicity environment. And I want to put the next question to Nadine, and it's a double-barreled question. So the first question is, when someone has an overdose in the community, what can people do to support that patient until paramedics arrive? And really around particularly the lack of a sort of an antidote therapy similar to how naloxone works with opiates. And then if the ambulance does come and the person is moved to hospital, how is that toxicity managed in the hospital setting? So kind of a double barrel there for you, Nadine.
Thanks, Krista. I think Erica ran through kind of the first aid approach to managing someone that is obtunded or has decreased conscious state. And as she pointed out, we don't actually know why. You won't know in that first instance. You can suspect that it's G, but it might be G plus benzos, G plus alcohol, or maybe they're also got diabetes or another kind of condition that's mimicking a GHB overdose. So we really don't know. So caution is always the best strategy. And Erica mentioned all the first aid things to do, so make sure you're not in danger first. Don't step out in front of traffic to help somebody. And then just check their response. And what we do, as Erica mentioned, is that we used to, if people remember, we used to do the sternal rub to try and wake people up, which actually looks a bit brutal. So we actually do a really strong squeeze here in the trapezius, and it really does need to be quite strong to rouse someone. And if they rouse, then you're not so worried. But if they really don't rouse and call their name and you can't rouse them, then you are seriously concerned. So then you do your airway, breathing, circulation, and the as Erica ran through, putting them in that side position so that their head's facing down, so that they can not inhale or vomit is really the safest way to do it. And I really loved Erica's comment about not standing in front of people, because if they sit up, they're going to clonk you in the nose, just as well as freaking themselves out. So that really is the best first aid. And if you can get someone else to call the ambulance while you're doing that, that would be really super too. And as also Erica pointed out, police are not supposed to come unless there's a threat to people's safety. So that it really should be safe. And the ambulance really are quite used to responding to people with health conditions that may or may not be related to substance use. So that really is the first step. And I love the fact that Erica mentioned naloxone. We don't know. We are increasingly concerned about opioids sneaking into all different sorts of drugs that people are purchasing. And we've seen some of the new synthetic opioids like nitazenes creep into some of the stimulants as well. So drugs that don't have a sedative effect that are expected to have a stimulant effect, like methamphetamine, cocaine, MDMA, they've all been occasions where those drugs have actually had some of the opioids in them. So you probably won't do any harm in giving some naloxone. Little spray available. It's actually widely available. We can, if you go online to the newer website, they also have they can post it out to you. That's NUAA, New South Wales Users and AIDS Association was what it's for. I guess the only caution to that is if someone is on opioid agonist therapy and they haven't had a GHB overdose and you give them naloxone, they're not going to thank you. But you really do need to be cautious with someone that is unconscious, that people can rapidly get blue lips, stop breathing, and actually sustain some brain damage permanently to that. To them from that. So then the next step is the ambulance comes along, they'll probably check to see if they're pinned, might give them some more naloxone if they suspect an opioid overdose, they'll check their blood sugar, all those other things probably on site, and get them to hospital, where we often end up having to intubate people because they really can't protect the airways and maintain their breathing rate at a rate that's sufficiently providing enough oxygen for their bodies and their brains. So people may get intubated, they end up with in intensive care, or they may be intubated in the emergency department. Most GHB poisonings are quite short-lived, so often people will wake up and regain full consciousness and leave the emergency department and go straight back to what they were doing. So it is usually quite short-lived, unless something else has happened, like people have taken another substance, or they've had sustained some brain damage, or any other range of problems like inhaling your vomit and getting a pneumonia from that. So usually that's quite short-lived, but it is life-saving. And in that EDNA case series that you discussed before, Krista, so that's the Emerging Drugs Network of Australia, they looked at a case series of different people presenting to the emergency department with GHB overdoses, and many people, we don't know what happened to the people that didn't make it to the emergency department, but some people were found in swimming pools behind the wheels of the car on their own. And so they were just lucky that someone found them and brought them in and saved their lives, because there's such a short window to actually save someone's life there. So really the other harm reduction message is really, if you can, use with someone else who knows what you're using. And I have seen some people write in texter on their arm, G, so that if they drop, people do know what's going on. So thinking about some of those kind of harm reduction measures so people can actually help you when you need help.
It's worth noting too, I mean, I think we've had a really good wrap of the data there from Jack as well, around just people articulating quite clearly that there is a certain level of comfort with managing overdose in the community, or that the fear of calling for emergency services means that there are probably a lot more harms that we can assume are happening in the community that we're not actually seeing in the hospital. And so some of those data around emergency department presentations are probably quite underreported really in that setting. I do want to, oh yeah.
One thing I wanted to add is that also you mentioned before about this kind of double reaction with GHB. So people can actually take maybe too much GHB for them and get very, very agitated. So many people have seen this kind of agitated delirium that we call it, that will be a precursor to then becoming rapidly unconscious. So if you do see someone with that very agitated, sweaty, running around, very energetic, that some people call it the G dance, when they're kind of being quite having rapid jerky movements, it is worth watching, because that can then be very, very rapidly followed with some drop in consciousness. And also in that Edna case series, that was what alerted many bystanders to something going on, someone behaving erratically and then suddenly becoming unconscious. But it does give you time to actually try and get some supports around that person and keep an eye out for them, so that if they do drop and become unconscious, you can be there to help them.
Yeah, Erica, you had some good reflections on that too.
One thing I think that's also, it can be very hard for people to want to call an ambulance, obviously for all the reasons it raised, but a good way of teaching people to communicate this, particularly if it's a sex on premises or an underground club or party, is you are going to get in more trouble if somebody dies on your site than having an ambulance rock up. The police will then come, and expressing that as a way to go, if we get an ambo, nothing's going to happen. But this event, this party will get shut down if somebody dies, and we won't be able to continue having this type of fun in the future. So kind of sometimes bringing that in can help with when you're working in less regulated spaces, because they often don't want to have any eyes on this space.
I think that brings us to the next. So there's a comment here just mentioning that one of the street names, there are so many, but one of them that someone has put in the comments here is Frank. So just that's on everyone's radar. I think I'll suggest that this one goes to Michelle and Jess. Somebody has commented in the question around how common it is to use GHB daily. The person who's posing the question has indicated that they had never heard of this previously, but recently have seen more clients who are using GHB daily. And so they just wanted to hear what your experience is around that, particularly probably in that withdrawal setting.
Yeah, absolutely. And I think here at St Vincent's and at Gorman Unit, we've been looking after people who needed to safely withdraw from G for quite some time, probably a little bit earlier than some places. So people using daily has become quite commonplace to some of our presentations. We are seeing an increase in admissions of people who are using G or G and other substances. And I think I was looking at trying to work out some data the other day, and I think we've seen an increase of around 17 to 20% this year on last year's presentations. And people are using, we get a lot of people who are using 20 to 30 mils a day, using hourly, waking overnight to use. And we've got people who are also using up to 100 mils a day, but some people who are also using, smaller amounts. But I guess that's when people are realizing that this substance use is becoming more problematic for them, because they are using daily and hourly, and then the risk of a more severe withdrawal is there. Anything?
Only anecdotally, I left another health district beginning of 2020 and came back 2022, and we were seeing maybe every 3 months someone coming in to withdraw from G, and then since coming back it's every week we've got maybe two or three, maybe even up to 4.
Yeah.
And that's just a gap of 3 years or 2 years really in between, that I've seen massive increase. Yeah.
And actually we probably would have more admissions than that a week, but we are quite cautious. Like Jess said before, we bring people in, we try and bring them in early in the week, so any potential complications happen when we've got a full complement of staff that can help. But also multiple admissions a day of using that substance puts us at risk of not being able to always monitor us safely, so we actually limit as well the amount. So I think we would see more presentations. But yeah, people using daily, hourly is much more commonplace.
And just in terms of harm minimization, this question may be for Jack, maybe for Erica, or you might like to take it together. What would you recommend in a harm minimization strategy? I know we always say start low, go slow. Is there anything else that you can say about deducing the strength of what's been purchased, or other than testing that low kind of amount? What can you give this person in terms of advice?
Erica, do you mind if I lead this one out, and I'll hand over to you to patch up anything I miss out? That's okay?
Go ahead. I was going to direct it to you.
Okay, great. So I think a lot of people who we spoke to throughout the GHB cultures, practices, and experiences study, and also just from my experience and community, spoke about kind of talking to friends and peers for batch strength reviews, essentially. Now, I think that that's a warranted and reasonable strategy to use. However, what we like to always remind people is that every occasion of GHB use is different, and there's a very narrow margin of a dose which causes a desired effect and a dose which can induce an undesired experience. And so we like to remind people that it's affected by kind of how much food you've consumed previously, other drugs or alcohol that you might have consumed previously that night, how much sleep you've had, how long it's been since you last used GHB, because we know that there's different tolerances to G between individuals, but there's also yourself, you have different tolerances at different points in time. So I think, you can do that batch strength review thing, but just be very mindful that every occasion of use is different. And so we always recommend sort of starting low to see. Erica, was there anything that you wanted to add?
I think there's sleep. I think we don't often pay enough attention that sleep deprivation really impacts your experience of drugs. It's just as dangerous to drive sleep deprived than it is to drive while intoxicated. I think making sure that you're also aware of different settings. As somebody who is a peer with living experience, you think your substances have worn off, and then you go into your bedroom when it's nice and quiet and you go, holy shit, I'm still really, really high. So we've got to be aware of how those different sights and sounds can impact the experience. I think without there being a regulated supply and drug checking facilities not being always particularly accessible, I think everything that Jack said is absolutely right. I think one of the things, making sure you've got barrels to actually measure, and it can be a bit corrosive, so potentially getting some tape to mark on it, because the dose is so sensitive. If you're getting it just from a bottle, you've got to shake it up beforehand to make sure it's a mixed dose. If you're just using the soy sauce fish, like every single one of those can be a slightly different measurement. And I think that's where you're making sure you've got the right equipment to make sure you're getting as close to the correct dose as possible.
We're running out of time, but I'm just going to have one more question that we can take for this afternoon session. And it's just around the strategy that someone's reporting having heard about a strategy in community about a peer-based management of G with an overdose being sort of treated, if you will, by a stimulant drug such as amphetamines or cocaine, for example. Jack, this came up in your data. Did you want to speak to this at all?
Look, the only thing I'll say to this is that we do see this. We saw a range of people using strategies to keep people responsive or alert, and those could be things like punching, biting, standing in the shower, which was often this like urgent, animated attempt to kind of keep someone from going into that state of reduced consciousness. We also saw people reporting, the use of stimulants. We always educate people that that can be quite an unpredictable how someone will respond to that, and so we don't advise the administration of additional stimulants in response to a potential GHB drop.
I just want to make a note as we close off the webinar. I do want to note that we've had a couple comments come through that are more discussion points. One particularly around working with men in a custodial setting, and seeing many clients who use GHB often alongside methamphetamine, which I think the data does support that that's often people will have, perhaps you saw in the South Australia data that I presented earlier. But this person also talks about, having quite a lot of harms come through risky practices around, in particular, this person mentions car chases with police, etc. And also just the tricky part of taking into account that everything that Erica and Nadine talked about prior to going to an emergency setting, just the tricky sort of discussion point around if you're working in a service, how you make that call as a service provider as opposed to a peer. I think probably all the same criteria apply. Nadine, I don't know if you have anything else to add to that.
No. I mean, I think you've already pointed out that we do need some more. It would be helpful if we had some more structured tools to assess the progression of delirium or other adverse events associated with GHB withdrawal, and I think we need to do some more work on some more structured management of the GHB withdrawal. Most people aren't going to have a severe withdrawal, but some people will have a severe withdrawal and can end up in intensive care due to the delirium associated with that. Seizures are less common. They're listed, if you read your list of things that can go on. Seizures is supposed to be one of the withdrawal effects, but we actually haven't seen that. We've seen delirium much more commonly.
Aware of the time, I want to thank all of our presenters today and everyone online who attended and engaged with this discussion. I want to remind everybody that the next NCCRED webinar seminar will be on the 27th of November. But in the meantime, you can also join us for our annual clinical research symposium, which will be held on Friday, the 22nd of November. The symposium will share international learnings on emerging drugs and information sharing networks and digital interventions to support people who use methamphetamine. Registration is free and it will be delivered in a hybrid model. So feel free if you're available to join us in Sydney or log in from wherever you are. So once again, thank you to everybody, and I hope you have a lovely afternoon.